Everybody doing today? I was scanning today. I did a couple of carotid studies, and one of the things that always frustrates me when we do those carotid studies and we encounter a patient near that threshold for intervention, we're actually asked to give a grading of the stenosis that we don't really do with ultrasound. This has been a problem for the last 15 or so years. Let me give you a few of my takes on this subject. When we do duplex ultrasound, we actually live by the gospel according to Gene Strandness. You do know who Gene Strandness is, right? You don't know who Gene Strandness is? You read a book. Read any books. Gene Strandness is the father of our technology. But he said that the tighter the stenosis, the higher the peak systolic velocity, and the greater the turbulence. That is, until that narrowing gets so severe that only a trickle goes through, and then it'll actually slow down a bit. He also noted that somewhere around a 70% diameter reduction, the end diastolic velocity will begin to increase a little bit, and then substantially, pretty rapidly after that. So we're looking at an internal carotid artery and we come across a stenosis. We use a spectral analysis to obtain that spectrum from within that stenosis. We can calculate the peak systolic velocity and the end diastolic velocity. That helps us categorize the severity of that disease. And here's the disease classifications that Gene Strandness and his group at the University of Washington put together for classifying the severity of an internal carotid artery stenosis. I'm sure you've seen this before. This is without a doubt the most widely published, and I would argue the most thoroughly validated of any criteria for any imaging test in the history of the world. Well, the first important threshold was about 50%, because it was at that point that the velocity began to increase, as well as the formation of a post-stenotic turbulence or flow disturbance. Additionally, his natural history study shows that this person went into a slightly increased risk of having symptoms. We can differentiate greater than from less than 50% by using a peak systolic velocity of 125 centimeters per second. Well, those same natural history studies also showed that patients with an 80% or greater stenosis went into an even greater risk of having symptoms. So that was an important threshold as well. The peak systolic velocity no longer helped us differentiate that category, but instead then we looked at the end diastolic velocity. And his data showed that an end diastolic velocity of greater than 140 centimeters per second was consistent with a greater than 80% stenosis and a significantly increased risk of symptoms from that ICA stenosis. Well, along came the North American symptomatic endarterectomy trial, and its purpose was to really investigate the efficacy of carotid endarterectomy in symptomatic patients. Without going into detail, basically this trial proved with little doubt that patients with a greater than 70% stenosis benefited from carotid endarterectomy. Well, the most important outcome of the NASCET trial for the sonographer was that this significantly impacted our interpretation of our duplex data. The first thing to note is that we didn't have a 70% criteria. Remember, our criteria was from 50 to 79% or from 80 to 99%. But however, the big thing is that it really changed our definition of stenosis. And it did that because it really changed the measurement methodology. The NASCET used an angiographic methodology, not an ultrasound methodology. And it's important to know that any of our pre-NASCET duplex criteria will not really correlate with this methodology. I'll explain. Well, our gold standard for duplex ultrasound, and actually what was used in the NASCET trial, was angiography. Well, the original validation studies were done using an angiographic or an X-ray technique in which flecks of calcium in the arterial wall were used to largely guesstimate where the arterial wall was. And then a percent stenosis was calculated. In the NASCET method, they did not estimate where the arterial wall was, but in fact, as the denominator, used what was considered the normal diameter of the distal ICA. So let's translate this to duplex. Here we see a normal internal carotid artery. We can see the residual lumen, A, and the original lumen, B. They're the same, no disease. So let's take that same ICA and we'll put in some plaque here. This looks like about a 50% diameter reduction. So we can measure the original lumen in A, and then we can measure the residual lumen, B, and calculate the stenosis, approximately 50% local stenosis. So if we do that same exercise using the NASCET measurement methodology, we would use B, the distal ICA, as the denominator, and this works out to a 0% stenosis. So let's add a little bit more plaque along the posterior wall. So now we can make our measurements again, A, the original lumen, and B, the residual lumen. If we calculate that out according to the ultrasound method, we have a 75% stenosis. So let's make that same measurement using the NASCET angiographic methodology, using the distal ICA as the denominator. You can see how this calculates out approximately 50% diameter reduction. I'll give you one more real-world example. Here's an ICA. We can clearly see that there's plaque within there. This is a little complicated by the calcium that causes an acoustic shadowing. However, the resultant measurement still looks pretty high quality. However, if we eyeball this, we can say with high certainty that using NASCET methodology, this would call this a 0% stenosis. It's important to understand that the NASCET measurement methodology significantly underestimates non-hemodynamically significant disease. So my suggestion, know what criteria you are using and how you got there. And it's also very important to know the measurement methodology of the correlative test that you're comparing your duplex scan with. Make sure you're comparing apples to apples. Hope you enjoyed this little synopsis on the difference between ultrasound and angiographic measurement methodology. If you're interested in learning a lot more, or you need to earn some Category 1 CME, please visit virtualveincenter.com. We appreciate it. Like, subscribe, you know what to do. We'll talk to you next week.